Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Okay, let's unpack this. Today, we're diving deep into a surgical procedure that really represents the pinnacle of precision in cancer treatment, Total Mesorectal Excision, or TME. This isn't just any surgery. It's considered the gold standard technique for treating rectal cancer.
That's right.
And our specific mission for you today, whether you're a seasoned surgeon, maybe a med student, or just someone really curious, is to walk you through the precise step-by-step journey of this complex surgery.
Yeah, highlighting the crucial bits.
Exactly, highlighting the crucial details and why each step matters so profoundly for the surgeon actually doing it. We'll even zoom in on one of its most intriguing elements.
Yeah.
The distal donut.
Yes, the donut. Very important.
Intrigued, good.
Well, what's truly fascinating here, I think, is how TME is just meticulously designed. It aims to achieve two absolutely critical goals at the same time.
Right.
First, the complete removal of the cancer. Surgeons call this en-bloc removal, which basically means the rectum and all its surrounding fatty tissue and lymph nodes, that's the mesorectum, are removed as one intact specimen. You want those fascial planes undisturbed.
Undisturbed, okay.
And second, just as importantly, preserving the patient's quality of life after the surgery.
That second part is huge.
It really is. So this isn't just, theory. It's a practical, detailed guide to a really meticulous process. It aims for the best oncologic and functional outcomes.
And you mentioned it can be done different ways, open, laparoscopic.
Yeah, exactly. We'll cover the core principles, but it's worth remembering TME can be done open, laparoscopically, or even robotically. But the fundamentals, that meticulous attention to detail, that stays consistent.
That dual goal eradicating cancer and preserving quality of life, it really does underscore the complexity, doesn't it?
It absolutely does.
So let's begin right at the start, laying the groundwork. Preoperative preparation. Before a surgeon even thinks TME, what are the absolute must-haves? Patient selection, diagnosis.
Okay, so it all starts with the definitive diagnosis. You have to confirm rectal adenocarcinoma through a biopsy. That's step one.
Got it. Biopsy first.
Then, precise staging is paramount. Think of it like creating a really detailed map of the cancer before you go in.
A map. I like that analogy.
We use an MRI, primarily, to determine the T and N status. The T tells us about the tumor size, how deep it's gone into the bowel wall. The N tells us if it's spread to nearby lymph nodes, sort of maps out its local aggressiveness.
T and N status, right.
And alongside that, usually a CT scan to check for distant metastases has the cancer travel to other organs, like the liver or lungs.
Okay.
These imaging tools are absolutely crucial because they inform the whole treatment strategy. That includes deciding if the patient needs neoadjuvant chemoradiation.
The treatment before surgery.
Exactly. Chemo or radiation or both, given beforehand to shrink the tumor, especially for larger or more advanced ones, T3 plus or N plus tumors.
So once we have that comprehensive map, that staging, we preps the patient internally. Let's talk bowel prep. I know mechanical bowel prep, cleaning things out, can be, optional. Depends on the surgeon.
It often does, yeah. Surgeon preference plays a big role there. But the antibiotic regimen, that's absolutely critical.
Okay, tell me about that. Why so critical?
It's all about minimizing infection risk. That's a major concern with any colon surgery, obviously. So it's usually a dual approach. Oral antibiotics, maybe like neomycin or erythromycin, to reduce bacteria in the gut.
Right.
And intravenous antibiotics, maybe cefazolin and metronidazole, given right before the procedure. This combo really knocks down the bacterial load in the colon, drastically lowers the chance of nasty postoperative infections.
Makes perfect sense. Hit it from both sides. And then the physical setup in the OR. Positioning, other prep, I imagine every little detail there contributes.
Oh, absolutely. Every detail counts. Optimal positioning is foundational. Typically, the patient is placed in what's called a modified Lloyd-Davies position.
Modified Lloyd-Davies. What does that look like?
So the patient's on their back. Legs are elevated and abducted in stirrups. That's the lithotomy part. And combined with a slight head-down tilt. Trendelenburg.
Okay, head down, legs up.
Yeah. This specific setup gives the surgeon the best possible access to the pelvis. Essential preps also include a Foley catheter for bladder drainage, sequential compression devices on the legs.
For clots.
Exactly, to prevent DVTs, blood clots, and sometimes an NG tube through the nose to the stomach if the surgeon thinks it's needed. Each element is there for optimal access, patient safety, and frankly, comfort during a potentially long case.
Okay, so patient meticulously prepped, positioned. We're ready to actually start the surgery. For the traditional route, open TME, what's that first incision like?
For an open TME, the standard approach is a midline laparotomy. So an incision from the xiphoid process, that little bone at the bottom of the sternum, all the way down to the pubic bone.
Big incision.
It is. And the very first step, once you're inside the abdomen, is a thorough exploration. The surgeon carefully feels, looks around, checks for any signs of liver or peritoneal metastasis, cancer spread, and assesses the tumor's mobility. Can it actually be moved?
So a reality check right at the start.
Precisely. It confirms resectability, helps plan the dissection, makes sure there aren't any nasty surprises.
Right. That makes sense for open. But what about the minimally invasive options, laparoscopic, robotic, TME? How do you get started there? What's different?
The main difference is port placement. Instead of one large incision, you use several small ones for instruments and a camera.
Ports, okay.
Typically maybe a 12-millimeter port at the umbilicus, the belly button for the camera, that's your main view. Then smaller, say 5-millimeter ports in the right and left lower quadrants. And often a 12-millimeter port just above the pubic bone, the suprapubic port that's key for getting the stapler in later.
Specific locations for specific jobs.
Exactly. And for robotic TME, you add the step of docking the robot. Often side docking with the patient tilted to optimize pelvic access for the robotic arms. These placements are all meticulously designed for the best views, the best instrument access to navigate that tricky pelvic anatomy.
Okay, so once we're in, whether open or MIS, we get to the real heart of it, the deep dissection. This sounds like where the real precision comes in. Medial to lateral dissection. What's the first move, and what are you immediately trying to protect?
So this dissection usually starts by carefully incising the peritoneum, that lining of the abdominal cavity, right at the sacral promontory, that bony landmark at the base of the spine.
Okay.
And from that very moment, a crucial focus is identifying and meticulously preserving the superior hypogastric plexus.
Nerves, right.
Vital nerves, a whole network of autonomic nerves critical for bladder, bowel, and importantly, sexual function.
And why is preserving those nerves so critical? What are the real-world consequences if they're damaged?
It's absolutely vital because even slight trauma to these delicate nerves can lead to significant, permanent, long-term problems. Urinary dysfunction, sexual dysfunction. It profoundly impacts the patient's quality of life after they've beaten the cancer. So maintaining their integrity is a key goal, right alongside getting the cancer out.
Wow. Okay. So nerve preservation is front and center. Then you deal with the blood supply, the inferior mesenteric artery, the IMA.
Correct. After protecting the nerves, you address the IMA ligation tying off that main artery. And surgeons have a choice here. You can do a high tie closer to the aorta.
Why do that?
Often preferred for a wider oncologic margin, maybe getting more lymph nodes. Or you can do a low tie further down below the takeoff of the left colic artery.
And the reason for a low tie?
Usually to preserve blood flow to the remaining colon segment, which can be important for healing the anastomosis later. It really highlights how surgeons tailor the operation based on the specific anatomy and the tumor.
Fascinating. These subtle choices with big impacts. After the vascular work, I know surgeons often mobilize the splenic flexure. Why is that done? What's the goal?
Splenic flexure mobilization?
Yeah.
That's done to ensure you get a tension-free anastomosis later on.
Tension-free connection.
Exactly. If the piece of colon you're bringing down to reconnect is stretched too tight, the risk of that connection leaking goes way up. And a leak is a serious complication you really want to avoid.
How do you mobilize it?
It involves carefully releasing the gastrocolic ligament, that tissue connecting the stomach and colon. You have to be careful there. Avoid injuring the spleen, which sits right nearby.
Ooh, yeah. Don't want that.
Definitely not. And then dividing the phreniocolic ligament, which tethers the colon up towards the diaphragm. This frees up enough length on the colon so it can reach down into the pelvis comfortably without any tension for that new connection.
Okay, makes sense. Get enough slack. Now, the TME itself, the core dissection, this is where that anatomical mastery really comes in. Let's start posteriorly. What's this holy plane I hear about?
The posterior dissection. This involves entering the presacral, or as it's often called, the holy plane.
Wildly.
Well, because if you're in the right plane, it's largely avascular bloodless. It's this potential space between the mesorectal fascia, that critical layer around the rectum and its fat, and the presacral fascia covering the sacrum bone.
Okay.
You use sharp dissection, usually with tools like electrocautery or ultrasonic shears that cut and seal vessels simultaneously. But the big danger here, the thing surgeons really respect, is avoiding the presacral veins.
What happens if you hit those?
Bleeding from those veins can be torrential and incredibly difficult to control. It can really obscure your view, make the whole procedure much harder and riskier.
So finding and staying in that holy, bloodless plane is key. You mentioned the mesorectal fascia. Why is keeping that layer intact so important?
Maintaining the integrity of that mesorectal fascia, keeping that envelope around the rectum and its fatty tissue completely intact, that is paramount. It's directly linked to better oncologic outcomes.
Meaning less cancer coming back.
Exactly. Lower rates of local recurrence, improved long-term survival. Before TME principles, focusing on preserving this fascia became standard, recurrence rates were much, much higher. Getting an R0 resection, no cancer cells left at the edge, often depends on keeping this fascia pristine. It's truly the art and science of TME combined.
Wow. Okay, so that's the posterior side. What about dissecting anteriorly, towards the front? Are there differences depending on the patient's sex?
Yes, absolutely distinct differences. In male patients, the dissection goes carefully behind Dennin-Villier's fascia, that's a fibrous layer to protect the seminal vesicles in the prostate, crucial for urinary and sexual function.
Right.
In female patients, the focus is on meticulously separating the rectum from the back wall of the vagina. Again, precise dissection to avoid injury to adjacent structures.
And laterally, dissecting out to the sides.
Still thinking about nerves.
Definitely. During lateral dissection, you divide the lateral stalks as sort of natural tethers holding the rectum sideways. And yes, nerve preservation is still a huge focus. You're working near the pelvic plexus here.
More nerves critical for function.
Absolutely. Essential for urinary and sexual function. Protecting them here, just like the superior hypogastric plexus higher up, is key to avoiding long-term problems. The dissection continues all the way down to the pelvic floor muscles, the levator ani muscle.
Got it. All the way down. So finally, you reach the point where you actually cut across the rectum below the tumor. Distal rectal transection. What's the crucial measurement surgeons are aiming for?
This is a really critical moment for clearing the cancer. You need an adequate distal margin. The standard goal is at least 1 centimeter of healthy rectum below the lowest edge of the tumor.
1 centimeter minimum.
Minimum. For very low tumors, sometimes surgeons aim for 2 centimeters, just for extra oncologic safety. And typically, a linear stapler, something like an echelon, is used for this transection. It cuts and staples the end closed in one go.
Okay, so the diseased part is out. Now you have to reconnect things. The anastomosis, how is that usually done after TME?
Most commonly, we use what's called the double stapling technique. It sounds complicated, but it's quite elegant. You insert the anvil, think of it as 1/2 of the stapler, into the end of the healthy proximal colon, the part coming down from above. You secure it there with a purse string suture, like pulling a drawstring tight.
Anvil in place.
Then the main body of the circular stapler is inserted through the anus up to the rectal stump where you just transected. You connect the anvil to the stapler shaft, close it, and fire. It creates this neat circular stapled connection, the anastomosis.
And that firing creates the famous distal donut.
Exactly. That firing cuts out a small ring of tissue from the rectal stump. That's your distal donut.
Okay, so the critical check. What are you looking for in that donut, and what does it signify?
This is a huge moment. You immediately inspect that donut. You need to see a complete intact ring of tissue, like a perfect, tiny tissue bagel.
A complete ring. What if it's not?
An incomplete donut is a major red flag. It suggests the staple line might not be intact, meaning a much higher risk of an anastomotic leak. A leak is a really serious complication, so this check gives immediate feedback on the technical quality of the anastomosis.
So it's a mechanical check. Any other reason to look closely?
Yes, also an oncologic check. If that margin on the donut looks worryingly close to where the tumor was, or if there's any doubt, you send it immediately for a frozen section.
Quick pathology check during the surgery.
Exactly. A rapid microscopic look to make sure there are no cancer cells right at that cut edge.
Wow, okay. Donut check passed, hopefully?
Yeah.
What's the final test for the integrity of that new connection? How do you know it's sealed?
The final belt and braces check is the air leak test, or sometimes called the bubble test.
Bubble test.
Yeah. You fill the pelvis with saline solution, submerging the anastomosis. Then you gently insufflate air into the rectum via the anus, using something like a proctoscope. You watch carefully.
Looking for bubbles.
Exactly. Any stream of bubbles coming from the staple line indicates a leak.
And if you see bubbles,
If a leak is detected, you have to fix it right then and there, usually by placing reinforcing sutures across that spot. This test is absolutely vital for patient safety. You need that anastomosis to be watertight. And again, having it tension-free and well vascularized is key for healing and preventing leaks in the first place.
Makes total sense. Test it before you leave.
Yeah.
Now, sometimes, even with a good anastomosis, surgeons opt for a temporary diversion, right? A loop ileostomy. When is that needed?
Yes, a loop ileostomy isn't always done, but it's often considered in higher risk situations.
Like what?
Like a very low anastomosis, down deep in the pelvis where healing can be trickier. Or if the patient had neoadjuvant therapy, as radiation can sometimes impair healing. Or, frankly, if there were any intraoperative concerns, a tough dissection, maybe a small leak that needed repair, or just a general feeling that things aren't quite perfect.
So a safety measure.
It's a safety valve, essentially. You create a temporary stoma, usually bringing a loop of the small bowel, the ileum, out onto the skin in the right lower abdomen.
Oh.
Stool exits into a bag, diverting the fecal stream away from the new connection while it heals safely.
Okay. And then the final steps, closing up. Any drains left behind.
Whether to place a pelvic drain is often surgeon preference. Some will place one near the anastomosis to drain any fluid collection. Others feel it's not necessary if the anastomosis looks good. It's a bit debated.
Right.
For closure itself, you close the fascia, those strong connective tissue layers, carefully, usually with a strong, long-lasting absorbable suture like PDS. Then the skin is closed, either with staples or maybe a subcuticular suture, which dissolves under the skin for a nicer cosmetic look.
And surgery is done. What about immediately after post-operative care? I keep hearing about ERA's protocols.
Yes, ERA's early recovery after surgery is really central now. It's a whole bundle of evidence-based practices designed to get patients recovering faster and better with fewer complications.
What does it involve?
Key components include getting patients up and walking very early ambulation, none of that lying in bed for days, and starting liquids pretty quickly, then advancing the diet to solids as tolerated. It's a big shift from older practices.
Moving and eating sooner.
Huh.
What else is crucial post-op?
Well, DVT prophylaxis is vital. Preventing blood clots with heparin shots are similar, plus those compression stockings.
Right.
And if the patient has that loop ileostomy, then stoma care is a huge part of recovery. Enterostomal therapy nurses are invaluable here, teaching the patient how to manage the stoma and the bag.
It's a specialized nursing support.
Absolutely essential. And finally, maybe the most important thing post-op is the final pathology report on the whole specimen that was removed.
Ah, the definitive answer.
Exactly. This confirms if it was an R0 resection, no cancer left at the margins. It assesses the CRM, the circumferential radial margin, that side margin, which is critical for local recurrence risk, and it counts the lymph nodes removed and how many had cancer. All this information is crucial for determining the patient's prognosis and deciding if any further treatment, like adjuvant chemo, is needed.
What an incredibly detailed journey, just recapping those key insights.
Yeah.
The importance of TME quality, that intact mesorectal fascia for good outcomes.
Critical.
The huge emphasis on nerve preservation for quality of life.
Absolutely.
That distal donut needing to be complete for a safe connection.
The immediate feedback moment.
And just the fundamental principles of making that anastomosis safe. Tension-free, good blood supply, and testing it thoroughly.
You've got it. That structured, detailed approach is really designed to optimize the cancer removal while doing everything possible to minimize complications. But, it's always tailored. You always have to adjust based on the specific tumor, the patient's anatomy, their overall health. It's where the surgical craft meets the science.
So, considering all this incredible precision, this meticulous care at every single stage, what do you think is the next frontier? How do we refine TME even further? Could it be, even more advanced imaging during the surgery, maybe AI helping guide the dissection to get that perfect complication-free donut every single time?
That's a fascinating thought.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.